Now we are starting the angiography of our patient who presented with chest pain. I'd like to tell you about the case I just finished. Our patient is a 45-year-old male. He has a significant family history. His uncles and father had heart attacks in their 40s and some had bypass surgery. Because of this, he actually had a cardiological examination about 4 years ago. As a cardiological test, a CT angiography was performed on the patient. And in this CT angiography, a 20 to 25% stenosis was found in the vessel we describe as the LAD, which feeds the front of the heart. This patient's risk factors appear to be smoking, low HDL cholesterol, relatively high LDL cholesterol, and his family history. After the CT angio he had about 4 years ago, although a serious risk reduction should have been done, meaning lowering cholesterol levels with intensive statin therapy, taking blood thinners. And of course, the patient should have quit smoking. Unfortunately, none of these were done. The patient presented to us with complaints of pain, a feeling of heaviness and pressure on the chest, which we describe as typical chest pain occurring with exertion and subsiding with rest for about 3 to 4 months. No risk reduction was performed, no treatment was started, and there was no treatment compliance in this patient. We decided to proceed directly with a coronary angiography. Here you can see his coronary angiography. We see that the stenosis we called 20 to 25% about 4 years ago has reached nearly 90% and has turned into a lesion we describe as dissected with irregular borders. We treated this lesion. I will show you the results of that. But I think there is something more important here. How important it is to perform proper risk reduction. If we had treated this patient properly with exercise, lifestyle modification, statin therapy, aspirin therapy, and of course, if the patient had quit smoking, perhaps we wouldn't have reached this outcome. We wouldn't have encountered such a coronary anatomy in such a short period as 4 years. I want to emphasize this. After the angiography we performed via the radial route, we continued to treat this patient using the same radial access. We treated it using what we call a provisional strategy, meaning a single stent, placing a stent in the main branch and using a drug-coated balloon for the side branch. Although the result is quite reasonable and good, what needs to be emphasized here is, first, if we had taken earlier precautions when we detected this lesion on CT angio, would it have reached this stage? And secondly, even if we have opened this vessel, we must manage the risk factors very accurately from now on. Lowering LDL levels below 70, using blood thinners regularly, eating a balanced and healthy diet, exercising regularly, and quitting smoking seem to be what needs to be done for this patient in the future.